Yes, so just even very practical. How are they going to get from their home to their appointment? You know, how many buses do they have to take? How many kids do they have to lug with them? Mary.
Opposed to us, which teach people how to cope in a different way rather than their medication, their card, and so give them tools so that they can operate healthy and
Yeah,
coped.
yeah. So maybe at one point in time this worked for you, but it doesn't seem like it's working now. What are some other things? Yeah. Anybody else have any thoughts about that?
Sometimes I think with some of our patients who've been very much engaged in negative behaviors, like the eating disorder patients for a very long period of time, they don't have sort of a sense of who they are, their inner self. And so discussions around, well, what do you want to do now? You know, what is the next thing? What is self-fulfilling to you? You know, are kind of important because the person is left without their coping skill of addiction, you know, addiction to starvation or
Yeah.
eating disorder.
Yeah.
And now what is left, right?
Yeah.
Who is that person?
Yeah, no, that's incredibly important because if you take something away, you have to put something there, whether it's an addiction of any sort, eating disorder, sex, gambling, substances, or if it's giving up a delusional system. You know, we've had patients who have had really shitty lives, but with their delusional system, everything's wonderful. Okay? And then we want them to give up that delusional system, being married to this star. And so something else has to go in there. And I think that this is incredibly important that for us to really help people figure out when they walk out. So they've got something more than the pills and an appointment. Okay, then of course it's a calm milieu. And we know what it's like. How many times have you been someplace, not someplace, particularly your work environment, how many times have you worked and one patient has gotten agitated and then suddenly it's like, bam, bam, down the hallway. You have one or more patients. Yeah. Because people when they are psychotic are very sensitive to what's going on around them. And so we're just going to take a real skip through milieu management real quick because I think it's incredibly important. This is another picture of Dr. Peplau. What I found really interesting when I started doing more research is that she was educated, she studied with Henry Stack Sullivan, Frieda Fromm-Reich, and Eric Fromm. So some very heavy hitters. And Joyce already went over this. And so Dr. Peplau talks about structured and unstructured. So structured milieu, you know, these are the easy things. We have to put them in place, and not every hospital has them. But, you know, organized, community meetings, groups, planned activities, clear boundaries for people, and clear expectations. I kind of like expectations better than rules. You know, we're going to orient somebody back to reality when we're able to. Adequate staff ratios. And then we're going to make sure that the environment is safe and comfortable for people. It's the unstructured that is the art of looking at the milieu. And so, and Lakita spoke about exactly what it is. So we know that this person who's having a hard time, they're going to be interacting with other people. What can we do to make the interaction either A, positive, or kind of head them off at the pass? You know, how do you talk to people on the unit who are kind of your nasty bullies and kind of corral them in so they're not making fun of the poor psychotic patient, who then gets angry and goes off? So all of these are the more subtle aspects of creating a calm milieu, and it really goes back to what Dr. Peplau had said about unstructured, the milieu, what we need to do. And these are not easy things. A new practitioner can't necessarily do this. We put them in the role and we support them, but they do not necessarily have the skills to be able to do it. So you have the milieu manager, and I think we've talked about this. And then the other thing that Dr. Peplau talks about that's so incredibly important is self-awareness. And she goes on really to say that when I am in a relationship with a patient, I should be learning too. And that's what I love about psychiatric nursing. You know, you can learn how to do a dressing, and maybe you do the dressing on the thigh, the back, the head. You get it all down within a couple months, unless you're really slow. But it's the self-awareness, and what did I learn from this patient? And when I did this group, how would I do it differently the next time? And, you know, often there's like little tweaking that, oh gosh, I wish I had broken it up and started from the left-hand side because people were getting bored, or... and so what we always talk about in CPM2 is we've got to know how I feel, and I've got to monitor how I feel then in relationship to the patient. It's not that I have to be so zen-like I have no feelings about anyone, and I'm fine with everybody, but it's knowing how I feel. What are some ways people do this? Because I know you do it, or else we would all be screaming and yelling all the time. What are ways that you identify your own emotions when you're working with somebody? Pat.
So when I first became a psychiatric nurse, I learned about the barometer, which was that all the hair would stand up on the back of my neck. When I was having a negative reaction to somebody, I felt like I had to control a situation or set unusual rules for that person. And so what I learned is that I had to process that with the team. It really was a way of identifying often some of the personality vulnerabilities of the person I was interacting with. And often, because we have that countertransference, it's very natural. But it's just being aware of it. I would have like just a visceral reaction and think, oh, that awful person. You know, and I'd think, well, wait a minute, I gotta go. Because it probably reminds me of somebody in my family.
Yeah.
Somewhere.
Yeah, and I think often we talk about countertransference in a way that we're not setting boundaries well because we like the person too much. I tend to think probably what happens more than what we realize is we have countertransference, and it's because the person's getting on our nerves. Now, it doesn't mean that they're not getting on our nerves for good reasons. But, you know, it's those cases we've got to be aware of so that we can interact with the person in a neutral way. I know for me, I feel like I get flushed. And then if I'm really smart, I don't say anything. If I'm not smart and I say something, I'm like, oh, I wish I hadn't said that. Anybody else have a way that they kind of monitor?
Usually we use each other. You can tell by, if you're working with a coworker and you can tell that individual, usually we will speak to one another, pull each other aside, usually with our floor, if we notice that there's something going on. But sometimes you're too overwhelmed or you don't want to think that it's happening, so you need someone else really to step in and
Yeah.
assist. So.
Yeah, and that's the old, you got a telephone call in the nurse's station. I really need you to take it now. Yeah.
Break off that cage.
Yeah, because we have to help our coworkers save face the same as with patients, right? You have to allow the patient to save face with behavioral changes. Okay, is this timeless or what? We are also busy all the time, and patients who make so many demands and yet do not seem to know what it is they want take up a lot of time needed for other work. So that was Dr. Peplau. I guess some things never change. And so what I want to address now is looking at frustration, because Dr. Peplau acknowledged that the patients get frustrated and anxious, and nursing staff, we get frustrated and anxious. And if you look at it, we got the same frustration, right? So first of all, it's interference or blocking of a barrier or goal. So for the patient, it can be, I don't feel like getting up. I'm not getting up. I'm not going to group. It could be, I want to get out of here. Could be, I don't want to eat, or it could be, I want to eat. And frustration for the nursing staff. You know, one, is it because you're overwhelmed and you've got so many things you're trying to get done? Is it because I'm trying to have a good conversation with you and you're not really helping me here? You're not answering my questions and I've got to document your assessment. And then, you know, we're all human, so it's the loss of dignity, of prestige. You know, if the patient is saying nasty things to me, that could hurt my feelings, right? I mean, because we all have that. And then frustration, conflict with peers, conflict with team members, and for us, it's just workplace conflict. So, you know, I think it's really important that we acknowledge this, so that one, we can help we can help patients, and we can help our peers, and we can ask for help for ourselves. And this was really, you know, if you look at Dr. Peplau's theory, it's something that she puts forth there to acknowledge for us. Okay, so I want to show you, hopefully this will be loud enough. This is an angry patient that I guarantee you all of us have had at one point in time, and then we're going to talk about the formulation of relationships with people like this.
You know, I'm not getting into that bed. What you're saying is you want me to help you. I don't want you anywhere near me. That's not you are. We need to set some ground rules, me and you. I could stay alone with you, but I'm not a guy. We good on that? I'm gonna get in the bed by myself. I'm not staying along with you. You just forget that. I'm sorry again. I'm sad to see you go. How about fresh air? Get you in a lot of work to do. Yeah, like to keep us fat peanuts really busy. These broads all look like they're half dead. I wouldn't want to be around these zombies. Gentlemen, who think you cut out for this way? No. Give me your arm.
Okay, I'm sorry, with the speakers it's not loud enough, but I think from looking at the body language you could get it.
Hi guys, this is Marvin, pharmacist manager, superintendent pharmacist.
Wow, that's loud enough. And so these, you know, I think often we have patients like this. And some people like cute, feisty old people, those who work on Meyer 6. Some people don't like cute, feisty old people. So what I'm going to do is call up our panel to have a seat. Come, panel. Let's see. I think that should be it. So we're going to be talking about this. And I want you to, I'm going to keep these up in the back. Thank you, our panel of experts. Okay, so if you could all take a minute, and we'll start with Melinda, and just introduce yourself in case people don't know you.
I'm Lakita Dyson. I'm an NC3 on Meyer 3, and I work primarily in the intensive treatment unit with our patients that are suffering from dual diagnosis.
And I'm Karen Pinella, and I'm a nurse on Meyer 3.
Okay, so we took these wonderful people from our audience, brought them up, and I gave them some questions. So what I'd like to have is just, I didn't give them to you? Oh. You must have been busy. I made many copies of the questions. There you go. And so what I'm hoping is you guys can give some of kind of the tricks that you have, and then if those in the audience can also respond with some things that you guys find helpful too. So one question I think of when you look at like that person who's like, I don't want to sit down, you fat horse, get the blood pressure cuff off, and obviously they do not want to be in the dependent role, which is good. But what kind of tricks do you do to meet the patient where they're at that point in time? Because we're not going to change that lady's mind.
I think I like the technique that Ann was talking about, which is lots of frequent brief interactions prior to asking for something, especially in my role where I have to get them to cooperate. So talking to people multiple times before I'm making them do something.
I think greeting. Someone said acknowledgement. Definitely greeting first, and just like you said, going back multiple times instead of your agenda. Find out what their, is there anything? Sometimes it's very difficult to pinpoint right away, but what can you offer them versus what can you offer them versus what can they give you that you want? What are you showing up for instead of showing up for what it is that you want to accomplish, because you're so familiar and best to go slow. Hello, can you hear me? So I think greeting and frequent contact, and make sure you show up with instead of your agenda, what it is that you're trying to accomplish, what it is that maybe you could help them with that they see. And in that case, it could be the simple basic needs of food and drink. And, one of the best compliments I got recently from a paranoid patient who was not very engaging, a lot of anhedonia, is, "Thank you, you seem to really care." And all I did was give him a warm blanket.
So I really like the idea of expressing empathy. So saying to the person, I understand that you are frustrated, and also maybe giving them some education. So some of our patients need vital signs every 4 hours, and they may not understand that. And I also, so that's it. So let's see, empathy, education, and I had one more, but I just cannot remember it. So we'll come back.
I want to echo what they said, and then I'll build on it by saying, oftentimes in my job, I have to make people do what you all find as comforting as offering food and drink. So a lot of my patients, is what they don't want to do. And so sometimes I just have to sit with them in silence and just say, all right, we're just going to take a time out. We're just going to kind of reset the clock. Or I'll ask them about something, what it is about it that's making them worried or upset, and not assuming that I know what they're feeling, because I might not. And sometimes that's all that it takes, is just kind of saying, all right, so tell me about this piece of cake. Why don't you want to eat it? What's going on? And that kind of actually helps me, like Karen was saying, learn from my patients, because I can't assume that I know why they're afraid of that. And that actually helps me connect with them, that I can then use it in a later encounter.
So for me, it is meeting the patient where they are at. So this came to me only with like life experience, being in psych for a long time, it didn't come for me like naturally. So this is something that I try to understand and picture patients in their shoes, and then able to empathize with them. So one of the example I can give is that like a week ago, a patient was sitting in front of the nurse's station, and she is supposed to have mittens because she is self-injury behavior and she's picking on her lips. Then as I was noticing her, one mitten had come off of her hand and she was continuing to do that behavior. So from the nurse's station, I smiled at her first, and then she smiled back. And then with the action, I said, "Put your mittens on." And then she smiled back and she did it. But if I was a younger nurse, I think I might have gone with like little bit power struggle there. So I could say now, because of the level of maturity, that I can use some type of little bit humor and engage them like that. So being professional, being respectful, and valuing them that they are human beings, and not having a preconceived notion that previously this patient cut herself and we did all these interventions, and now we are trying this method to put the mittens on. Now she's testing us. Yeah.
Yeah, I think that's a good point. I think about when I became a nurse 20 years ago, we were taught about a line in the sand. You know, don't let them cross the line in the sand. And as time has gone on, I think a lot with Karen's help too, come to see that negotiation and also values, like discussing values with patients is important, because that's where change comes from. You know, if the patient values something, what it might not be what your value is, but you know, they want to get out of the hospital, say. That's their value. Well, how do we work with that towards making a change, right?
So what I just remembered that I was going to say is giving patients options, because I think that can lead to frustration. So it may not be that the patient doesn't, using that example, the patient doesn't want their blood pressure to be done, but they just don't want it to be done at that time. Perhaps they had some other tasks that they wanted to do. So to say to the patient, can I come back in a half hour? Can I come back in an hour? Also, many times what we see on Meyer 3 is patients have built rapport with certain staff members. It may not be a nurse, it may not be a tech, it may be a unit assistant. So having that person be a bridge between you and the patient, having that person stand nearby to reassure that patient that you are a safe person.
I think too, in looking at this example here with the anger, the outward expression of anger, is one thing that I've learned is to not take it personally. That it's not about usually me, that people are going through what they're going through, and it helps, I feel like, to that I can use myself better when I'm less caught up in the in making it about me, and realizing that that they're going through something, and then use empathy to seek understanding. What is it that they are going through and experiencing that makes them display outwardly the feelings or thoughts that they're having. So I think that helps me to better find common ground, because I'm not all caught up emotionally in what they're experiencing, but rather trying to understand it.
I think another thing too, sorry, they just keep popping up like popcorn, is that being consistent with your patient across doing what you say you're going to do, or not doing what you're telling them that you're not going to do, and making sure that that lives throughout all staff. I think provides the patient with a feeling of safety, because then they know what to expect. Because if you're feeling chaotic and you're feeling unsafe and you're feeling untethered, if they can turn to that and say, okay, I know where I'm supposed to be, and I know that if I'm not there, they're going to come and get me, and this is what's going to happen. I've had a number of patients say that although they fight tooth and nail about the consistency and about the expectations, it provides them with safety, and that starts that, that relationship. And you can see when it's not followed, chaos generally ensues. So.
In line with that, I think follow through. That if you say that you're going to do something, in this particular case, I might realize that this is a woman who's alive and kicking and maybe doesn't need their blood pressure taken at that moment. So, you know, I would just maybe say, you know, I do need to get your blood pressure, but maybe I'll come back in 10 minutes, but you do come back in 10 minutes. You find that, you make that sort of a priority of something so that they know what to expect, they know you mean what you say, and that establishes that trust that you're trying to achieve so that you can, you know, start a rapport.
So another question I have for you then is, in dealing with people who are very challenging, and sometimes it can seem like there's days of this, what do you do that helps you still get some reward from it? So that when you walk out at the end of the day, you're able to kind of say to yourself, okay, you know, I got this done, or I feel good about this.
I think you have to dig deep, and sometimes you have to dig real deep to find something that went well, and it could be that the patient didn't hit anyone that day, or that everyone remained safe, or I think Melinda and I oftentimes say, well, everyone's alive, so that's a good day. And really using humor, I think, is so helpful, and using each other and kind of bouncing stuff up and just saying, oh my God, that was such a horrible day, and just kind of knowing that it was a shared experience and that you didn't do it by yourself, I think is helpful. But finding something that you did well, like, okay, well, I got the patient to not hit somebody today, or I kept them out of seclusion, or I helped them do this, even if it's teeny tiny, but that kind of helps you kind of keep going, that you made a difference on that day. Let's call it Pontiac, but that's okay.
So I think when patients have their illness, it's more like the journey that they are going to take on this path. So as a nurse, I think I would be more like their guide. So this journey can take a detour, stop, or they can like relapse back. So I should be open to that because I'm just a guide, and I should be like a cheerleader motivating them to reach towards the patient's goal.
Yeah, I mean, they all said that one. I got nothing. But I do think that we all go into psychiatry for our own reasons, you know, and you have to sort of examine that. And I think over time I've come to realize I kind of like difficult people, and I like the challenge of working with difficult people, and that there's some personal joy in seeing somebody who's struggling so hard, just even make the smallest steps, you know. And I think probably everybody in this room knows why you went into psychiatry. You know, we like these kind of patients.